The topic of today, I am dealing with various embolization materials used in interventional neurology and briefly about AVM embolization. So, what is embolization? Embolization is a process by which the introduction of various substances into circulation so as to occlude or arrest a vessel to prevent hemorrhage or arrest hemorrhage, or to devitalize a structure like tumor or an organ by occluding its blood supply. So, what are the therapeutic goals of embolization? It can be it has got an adjunctive role, curative role, and palliative role. It can be preoperative in cases of large AVMs, and in tumors it can act as a pre-chemotherapy and also in pre-radiotherapy. And it has also got definitive curative role in AV fistulas, aneurysms, bleeding, etc. And it has a palliative role in case of large AVMs, especially to relieve symptoms related to neurological deficits and headache. So, coming to brief history of embolizing agents, the first ever embolizing agent was autologous blood clot. It can be easily prepared by aspirating around 20 ml of patient's own blood and allowing it to clot. And when it is allowed to clot, there is a supernatant which is formed of acellular plasma which can be discarded, and the remaining the fibrin clot which is formed above the RBC base, which can be used as an embolizing agent. So advantage it is easily and quickly obtained, and it is very cheap, and due to biocompatible nature, it has less allergic reactions. But the problem is that due to body's own hemostatic mechanism, this natural clot which will lies within hours, 2 days. Even if nevertheless it is used as after the biopsy of lung lesions, and epidural blood patch is used in post-dural puncture, low CSF pressure syndromes, and also in priapism. This is how we inject epidural blood patch in case of CSF leaks post lumbar drain. So, coming to embolic agents in general, they can be divided as temporary agents and permanent agents. The permanent agents can be divided into particles, coils, liquid agents, and other agents. Coming to the agents which is used for embolization will depend on the vascular territory to be embolized and how much amount of occlusion we need for the vessel. The position of vessel is proximal or distal, and also depending on the whether we need to occlude the vessel temporarily or permanently. So, for permanently occluding the large vessels, coils, balloons, and emblaster vascular plugs are being used. And if you want to permanently occlude a small vessel, then particles, liquid embolic agents can be used. If you want to temporarily occlude a large vessel, then gel foam, sponge, and autologous blood clot are used. And for temporarily occluding small vessels, gel foam powder, microspheres, and fibrillated collagen are used. Coming to each embolic agent in specifically, first coming to gel foam. Gel foam is made up of purified skin gelatin. It was initially used for treatment of CCFs. It is available in sheets and powder. The gel foam is cut into small 1 to 2 millimeters pieces, and which is injected with the dilute contrast. It can be made as a plugget or as a slurry. So, what is mechanism of action of gel foam? It aggregates and swells on hydration into larger particles, thereby causing mechanical obstruction, slowing of flow, and thrombus formation. So, it is temporary in nature, and it can be used in trauma and hemoptysis, and it is cheap. but it has a risk of infection because air bubbles can be trapped inside this gel form, and some risk of ischemia due to low size of these particles. So if the patient we desire a proximal occlusion, then this kind of torpedo forms are being produced, and this is formed by compressing and rolling the strips of gel form, and can be loaded to the nozzle of a 1 or 3 ml syringe. If distal embolization is needed, then the small particles, these slurry can be formed by agitating the gel form particles with the 2 syringes, and this will form the slurry, which can be used for distal embolization. This gel form embolization provide temporary occlusion for about 3 to 6 weeks. Coming to particles, the most common used particle is PVA, polyvinyl alcohol. It was used since 1974. This is a permanent embolizing agent. This is made from polyvinyl alcohol sheets, which is vacuum dried and rasped into particles, which are filtered by sieves of filtering devices. And these are available from sizes ranging from 50 to 2000 micrometer. So this is a PVA particle, which is of a specified size. This is 300 to 500 micron. So what they act like is they have irregular in shape. They are multiple shape, oval, oblong, and this irregular shape promotes aggregation. And when they are injected, they adhere to the vessel wall, and they are causing stagnation of flow, inflammatory reaction, and fibrosis, and thereby permanent occlusion. So these are used in uterine fibroid embolization, JNA, juvenile nasal angiopharyngioma, bronchial artery, portal vein, and also in MMA embolization, PVA particles are used. So it can also occlude the proximal vessel due to irregular shape, and if it causes catheter occlusion and can lead to non-target embolization. If small particles less than 100 microgram are used, there is a significant risk of infarction due to distal vessel occlusion. This is how PVA particles are injected in a case of uterine fibroid. Coming to next permanent particles, these are embospheres. Embospheres are trisacryl gelatin microspheres, which are precisely calibrated spherical hydrophilic microporous beads made up of acrylic polymer, which is cross-linked with a porcine gelatin. This hydrophilic surface prevents aggregation, allowing more predictable uniform vessel occlusion than polyvinyl alcohol, as well as easily delivered through small catheters. These are embospheres, which are available in various sizes in vials, and this is how the embospheres are injected to specific vessels. They appear as smooth spherical particles and causing the permanent occlusion. This is how the uterine fibroid is being catheterized with a small microcatheter, and the embospheres are released into circulation. This principle is also used in malignancies, where these embospheres are embedded with radioactive substances like yttrium, which is used for treating hepatic carcinomas. And this is radioactive cis particles, spheres in microsphere, which causes targeted embolization of hepatic microadenomas. And these embospheres are have similar mechanism of action as PVA particles. They adhere to vessel walls, cause stagnation of blood flow, causes inflammatory reaction, and permanent occlusion. Because the regular spherical nature, this the particle accumulation in the catheter tube is uncommon compared to PVA, but this need a brisk steering to avoid sedimentations. And since this is made up of porcine gelatin, there is a chance of allergic reaction. And should be adequate sizing. Otherwise, compared to PVA, since same size particles can cause deeper penetration compared to PVA in embospheres. So we have seen it is used for uterine artery embolization, liver embolization, especially in tumors, and it can be used in meningiomas and also in facial AVMs. Coming to coils. The first ever coils initially was made in 1975, which was made up of pieces of stainless steel guide wire onto which strands of wool has been woven to form a thrombogenic material. These stainless steels are used for high flow application due to high radial force, and this high radial force of steel prevents dislodging. Now we use more platinum coils, which is steadily visible under fluoroscopy and which is much smaller than the steel coils. And there should be appropriate sizing to ensure the occlusion of vessel at the intended location. So what coils will do, it will slow the blood flow and it will cause vessel wall damage and release of thrombogenic materials and formation of clot. So coils are available in various sizes, lengths, diameter, and shapes. The coils are maximally used in aneurysm coiling, embolization. The filling coils, which are filling coils, framing coils, and finishing coils, which are available in various shapes and sizes. And it can be bare or fibered with materials like dacrum, nylon, etc. to increase the thrombogenicity of the coils. It is very easy to see, control, and display, and it can cause complete occlusion of vessels. But if not careful, it can cause occlusion of non-target vessels, and if undersized, there is higher chance of coil migration, which can cause pulmonary embolism, strokes, and myocardial infarctions. Then there is chance of dissection and perforation and vessel rupture, and infection and allergic reactions are reported rarely. So to occlude a vessel, the coil should be sized 20 to 30% larger than what the vessel measures on pre-deployment angiogram. So coils are mainly used for embolization, including treatment of hemorrhage and aneurysms, and also AV fistulas. And the main goal of the coil use is in unruptured aneurysms and to prevent bleeding, and also in ruptured aneurysms. And whenever the coils, this embolization with the coils produce this focal occlusion, and the distal vessels are patent, similar to a surgical ligation. So the coils are used in almost all applications where precise vessel occlusion, not tissue ablation, is necessary. So based on the methods of delivery, coils can be pushable coils, injectable coils, and detachable coils. So pushable coils are used in peripheral and cerebral embolization. This is a special guide wire with a bulbous tip, which is used to push the coil through an end hole catheter to a desired position. It is readily available and cheap compared to detachable coils. And once it is deployed, the reposition is not possible, and it can get trapped if there is a very difficult curvature, and in sharp curves it can get trapped. That is a disadvantage of pushable coil, and it is not compatible with the catheter, it can get jammed. This is the pushable coil, which is used in which is used to push the coils through a desired microcatheter. And next is injectable coils, which are also called liquid coils. these are very much softer compared to the pushable coils. And so it is non-fibered and the size is usually smaller, and it can be injected through a catheter with a saline or contrast, and it is usually quicker and can be deployed by injection of contrast. And the advantage is that since it is softer and it can accommodate any tortuous vessel, and there is tight coil compaction with injection. But if if it is vigorously injected, there is a chance of catheter pushing the catheter back, and there is a risk of non-target embolization. Coming to detachable coils, the first detachable coils was discovered by in 1977 by Professor Jane Turco. Initially, it was discovered for embolization renal tumors, and it is very extremely soft coils. Now, platinum coils are being used. This platinum coils is fixed to stainless wire, delivery wire, and it is available of various shapes, especially for treatment of aneurysms. The detachable coils are used. This based on the detachment mechanism is of different types. One is mechanically, the other is electrolytically, and other is hydrolytic. So because of the complexity, it is expensive, and there is a larger setup time is needed, and there is a risk of detachment, inadvertent detachments during wire manipulation. So what is the mechanical detachment of detachable coils? It includes the interlocking of mechanical detachment with a screw release mechanism. The interlocking mechanism means it uses small metal beads or hinge at the tip of the coil and at the end of the wire, and the coil is fastened by overlapping the beads hinge, and within the catheter coil is attached. But once it get out of the coil, the beads got separated and coil is released. This is a mechanical detachment. But the disadvantage is it can rotate or flip at the detachment, or flip, causing inadvertent detachment during wire manipulation. The most commonly used in aneurysm is electrolytic detachment. Initially, it was founded by the Gudelemy in 1991. The Gudelemy coil is non-fibered, extremely soft, uncoated platinum coil, which is attached to a stainless steel delivery wire. And this coil is welded to a pusher wire in the desired position. And how to detach is it is attached to a battery device. Then the current melts this welding and detaches the coil. Now we usually use the platinum coil, which is welded to the platinum tungsten alloy, which has got a high rate of electrical detachment. Usually the 1 milliampere current is used, and 2 milliampere current can be used to detach coil more quickly. These coils are very, because of platinum, they have good tractability, softness, and visibility under fluoro. And this can be again repositioned, and coil configuration can be changed. And even complete coil removal is possible before detachment. But sometimes it can prematurely got detached, and there is slipping of a proximal end into microcatheter, and there is a chance of, due to heat generation, the detachment may sometimes fail. The hydrostatic detachment system includes the use of a balloon. There is a balloon which is attached to the end of the micro delivery tube. And once the desired coil is in place, the inflator syringe is used to inflate the balloon, which on expanding causes the release of the coil. But this release of the micro balloon can cause the motion of coils during this release. This is a disadvantage of this hydrostatic detachment. These are the various coils used for one is this the detachable coil for intracranial coiling. This is the pushable coil, which are fibers for increased thrombogenicity. Various coils, this is the JDC coils and various shaped coils which are used in aneurysm coiling. Coming to hydrogel coils, which is also a detachable platinum coils, which is coated with a polymer. So what happens is that when it is detached, this polymer in around the coil expands and the diameter of the coil increases. And this expansion usually occurs within 20 minutes. And these are extremely soft and non-fibered platinum coils. And it expands and conform to spaces when they are injected. So there is a good volume expansion with these hydrogel coils, and it is more causing more occlusion than the regular coils. And it does not depend on the thrombus formation, and it has ability to accommodate a tortuous anatomy and ability to flow to target vessel to the catheter. But if it is the non-compatible catheter is used, then there is a chance of stuck inside the catheter. These are hydrogel coils. This is coated with the hydrogel polymer. On release, this will expand and entirely fills into the cavity. So other materials used for permanent occlusion is detachable balloon, which was initially used for CCF. It is made up of either lactose or silicone, and it is also used in pulmonary AVMs, large vessel, other large vessel occlusions. So detachable balloons can occlude large vessels, and it can be repositioned also by deflating. But there is a significant risk of rupture of vessels, deflation, migration, and premature detachment. This is balloon-assisted coiling of aneurysm sac. Second, large vessel for large vessel occlusion. This is a new device, Amblaster vascular plug device, which is an expandable nitinol mesh occlusion device. It is of two types. One device is thicker disc, and second device, the Amblaster 2 device, is a thin disc. So these have stainless steel screw attachment to a delivery wire, and they have got radio opaque blinds, and these are used for occluding internal iliac artery, mesenteric artery, renal arteries, portal vein, and splenic arteries. These are the structure of the Amblaster vascular plug devices. They have a 3D direction, and it can be used to occlude large vessels. So this can occlude a large vessel and thereby reducing the need for multiple coils, so as to reduce the cost and procedure time. But it should be used in a straight segment of vessels, and it does not cause immediate thrombosis. So they depend on the patient's ability to form complex. So it is not advised in coagulopathies. Coming to permanent liquid agents, which is most used in treatment of AV malformations. The first one is glue. Glue is nothing other than N-butyl cyanoacrylate, also known as NBCA. So NBCA is a free polymer. What happens is that when it is come in contact with an anionic environment such as blood or water, it it polymerizes. It is very fast acting, and for carrying this NBCA, it is ethiodol, which is a mixture of iodine and poppy seed oil. It acts as a vehicle for this NBCA and also an arrest polymerization. To prevent early polymerization, this ethiodol is used. So depending on the various requirement, the mixture of the NBCA and ethiodol are changed. And tantalum powder can be also added along with the ethiodol to increase the opacification for better visualization. So when this NBCA is injected, it adheres to the vessel wall and cause quick inflammatory reactions, and also this is followed by chronic inflammation. And this is the most quicker embolization agent. So to avoid the unintended polymerization by premature contact, the catheter should be flushed with 5% dextrose intermittently, and then this requires a special setup, that is NBCA compatible 3-way stopcock and syringes are needed. And due to its quick action, the catheter tip should be retracted to avoid adhesion of catheter to the with the NBCA. So the advantages of glue include it is permanent occluder, and it will not depend on the patient coagulation status, and it can completely occlude vessels and act very quickly. But the problem is that due to quick polymerization, it can get entrapped in the occluded vessel, and there is a great difficult learning curve for glue injections, and inadvertent injection can lead to reflux or spreading to distally and causing much serious problems. So these are the various available glues various places. The histoacryl glue as the NBCA, which was initially used. The glue brand and Magic Glue are most used, and also Trufil is used, and this is available in China, Fuel Aid. Coming to the next liquid embolic agent, this is the Onyx, which is the most commonly recently used in AVMs. This was first used by Dr. Taki in 1990. It was FDA approved for treatment of AVMs in 2005. Onyx is ethylene vinyl alcohol copolymer with DAMSO, that is dimethyl sulfoxide, as a solvent. So it also use tantalum powder for opacification. And the mechanism of action is that if Onyx is injected to a target lesion, the DMSO solvent rapidly diffuses away. This causes precipitation of the Onyx, and this forms the Onyx cast. So the Onyx is available as a separate in a separate container and along with the DMSO. So this Onyx, when come to contact with blood, this DMSO diffuses away, and this causes polymerization of Onyx and forms Onyx cast. So compared to glue, it is less adhesive, and this less adhesive nature allows long injection times, and we can temporarily suspend embolization, and we can look and we can slowly proceed as compared to glue. But this DMSO should be compatible with the catheter, and more DMSO can cause toxicity and vasospasm and necrosis. So injection rate of Onyx should be very low, 0.2 ml per second, and should be long. So this is the Onyx. The Onyx, which is initially DMSO is injected, and when it is diffused away, then onyx cast is formed, causing the permanent occlusion of the vessel. Absolute alcohol, although it is not an embolic agent, it is a denaturing agent. So it is an occlusive agent. So it acts by denaturation of proteins, thereby causing thrombosis and fibrosis and infarction. So alcohol is used because it is cheap and easily available. But the problem is its toxicity. It is difficult to control alcohol injections, and it is lacking opacity, and it can get absorbed into systemic circulation, causing problems like arrhythmias, hypotension, etc. And it is used for embolization, renal tumors, and thyroid nodules, etc. Calcium alginate is a newer agent. It is a polymer of alginic acid. When mixed with calcium chloride, forms a non-adhesive gel form. So it can fill the entire structure, unlike the coils, and it won't occlude the catheter because it is concentrically injected. But there is a lack of clinical experience with the calcium alginate, and it is not very much used. Coming to embolization, AVM embolization briefly. So all AVMs are not embolized. So the curative rate of embolization, curative success of embolization is around 30 to 50% smaller AVMs, and it has only very much less role in larger AVMs. So not the AVM embolization is done as a pre-stereostatic radiosurgery measure, as a rescue embolization, and also pre-surgically to reduce the size of AVM. Embolization can be done. And in inoperable AVMs, embolization is usually done to reduce the frequency of neurological deficits due to the steal phenomenon or venous hypertension, and also to relieve headache. And also the risk factors like intraneedle aneurysms can be treated endovascularly, and this will make AVM more before other therapies. So stereostatic radiosurgery, once the AVM is bled, the SRS cannot be done immediately because it will take 2 years for the obliteration of AVM. So as an initial rescue therapy, the embolization can be done. So when it is prohibiting vascular anatomy, it is a contraindication. There is excess vessel occlusion or stenosis, and in coagulation disorder and heparin sensitivity and sepsis. These are relative contraindication for the embolization of AVMs. So initially, the flow-directed steel spears were used in 1960s to block AVMs. Then in detachable balloons came, and then came the time of acrylates, cyanoacrylates. So what we do in AVM embolization is we have to access the vessel with a gate catheter and a micro catheter which is compatible with this either DMSO or this cyanoacrylate should be selected, and the desired embolic agent is to be injected to the target vessel. So the intervention phase can be divided into access phase, then this microcatheter access phase, and the final embolization phase. The cerebral AVMs are usually done under general anesthesia. Usually femoral artery is punctured, and usual anticoagulations is given as a dose of 70 units per kg. And the guided catheter of adequate French should be inserted, and proper angiogram should be done to evaluate all 6 vessel angiography should be done to find target, which all target should be embolized, and the roadmap should be placed for microcatheter advancement. Though these are the various microcatheters which are used in glue embolization. The MAGIC is the most commonly used AVM microcatheter, and detachable tip microcatheter are also available, Marathon, and also these other catheters are microcatheters are Ultra4 and Headway Duo. MAGIC is the most commonly used AVM catheter. So it is prepared in separate vials, and what concentration of glue should be used for AVMs is that first we have to take a shoot, and we should calculate the time required for the contrast to reach the lesion. If the transit time is less than 1 second, that is means a high flow fistula, then the 70% or more concentration of glue can be used. That is 3:1, 3 NBCA to 1 ethiodol can be used. If it is a low flow fistula, if the transit time is more than 2 seconds, 50% or less concentration of NBCA is only required. This is a low flowing fistula, so less concentration of NBCA is required for these lesions. And if there is a high flow fistula, then the concentration of NBCA can be increased. This is a rough table for calculating the concentration of glue. So glue is prepared separately, and the catheter is flushed with 5% dextrose, and glue compatible 3-way stopcock is needed. And for the injection of glue, various techniques are being advised. This is the wedge technique, which is continuous but steady injection of glue to occlude the arterial feeders and most of the needles, and inject till the AVM is almost completely filled. And if there is any reflex or the glue goes distally to the veins, then stop the injection, and retry if there is any remnant or till there is no reflex. Wedging is the placement of microcatheter to much distally to the feeders, and the push technique means the microcatheter is placed more proximally and injected. Glue is injected briefly, although triple technique is similar to the full column technique, but it is on and off injection of onyx to form a separate precipitate, and it will go to the arterial feeders one after another. So while injecting the AVM, the safety zone of injection is like this. We should not go beyond the nidus, other branches of the nidal draining, and it should be distal to the normal vessel supplying the normal anatomy. Microcatheter should be distal, and there should not be a reflex to the draining veins. This is onyx embolization. And the onyx embolization, the solvent is DMSO. The catheter is initially flushed with DMSO. Then by injecting onyx. This is the onyx cast. This is black onyx cast which is formed on contact with the blood. And so these are the DMSO compatible microcatheters. Marathon, Apollo. Apollo has got a detachable tip, and others has headway, ultraflow, echelon, and sonic catheter. Sonic catheter is also has a detachable tip. So the onyx should be initially put in a shaker for 30 around half an hour. Then it should be taken in a special proper syringe, which is supplied by the manufacturer itself. And initially, the catheter should be DMO flushed with the DMSO, and the hub should be vertically kept, and the hub should occupied by DMSO. Then the syringe with the onyx is put at an angle of 45 degrees, and suddenly it is kept in a vertical position, so that the DMSO should be lying in the upper part, and the high density onyx is in the lower part, and it can be injected. It is available in 34 and 18 in sizes, and 34 size is used for big feeders, and 18 size is usually used for small arterial feeders. So even though it can be injected slower than the onyx, don't pause the injection for more than 2 minutes, because it can solidify and clog the microcatheter. Never push against a resistance. And if microcatheter is clogged, then it can burst. So one adequate filling of the target feeder vessels is achieved, then stop injecting. Aspirate back the syringe from the microcatheter, and slowly and steadily pull back the microcatheter and disengage it from onyx. And once the microcatheter is withdrawn, the RHV of the gate catheter should be examined for retained droplets of onyx, and it should be aspirated and should be double flushed. And gate catheter also should be inspected and thoroughly flushed. And again, a follow-up gate catheter angiogram should be done. This is a small video how an access is made to the desired vessels, and the microcatheter is placed towards the desired position. Then arterial feeders should be identified, and this onyx is injected till it is the blood supply through the arterial feeders and nidus is stopped, and there should not be any reflux of the onyx to the other materials. After complete obliteration of the blood supply, this procedure can be stopped. So after the embolization of AVMs, there should be an immediate assessment of neurological status. The patient should be admitted to ICU, and the vitals and other neurology examination should be done every hourly. And if there is a complaint of headache, then the CT should be repeated. Sometimes headache can be due to irritation due to the embolizing agent and inflammation. In that cases, steroids are useful, and antiplatelets can be used for if there is any placement of stent, and strictly monitor the blood pressure. These are the agents which are similar to onyx. This is Scute. Scute is very much similar to onyx, except that the tantalum size is small compared to that of onyx. So it is more visible. The artifact caused by this tantalum is less in Scute compared to onyx. Minox is an Indian-made version of onyx, and Phil is a different combination of this ethylene vinyl alcohol, and this is and the radiopacking material used in fill is different. And the advantage it is that it is of low density and there is less degree of imaging artifacts. So what can be complications? There can be microcatheter access related complications like vessel rupture, dissection, etc. Then thromboembolic complications are always possible. There is a syndrome called post-embolization syndrome, which is due to the inflammation, which is caused by the occlusion of blood flow, that is characterized by fever, and other features. And there is a chance of AVM rupture. There is chance of other complications, rare complications, malignant cerebral edema, brain abscess, the blockage and clogging of microcatheter, seizures, and due to if embolization is not proper, and there can be a chance of other neural deficits. And there is chance non-neurological complication include chances of embolization to other circulation, and there is a risk for anaphylactic reactions, the puncture-related complications, and DVT. So, thank you.